Hello, everyone, and welcome to the Testing Psychologist podcast. I'm your host, Dr. Jeremy Sharp, licensed psychologist, group practice owner, and private practice coach. Many of y'all know that I have been using therapy notes as our practice EHR for over 10 years now. I've looked at others, and I just keep coming back to therapy notes because they do it all. If you're interested in an EHR for your practice, you can get 2 free months of therapy notes by going to thetestingpsychologist.com/therapy notes and enter the code TESTING.
This episode is brought to you by PAR. PAR offers the spectra indices of psychopathology, a hierarchical dimensional look at adult psychopathology. The spectra is available for paper and pencil assessment or administration and scoring via PAR iConnect. Learn more at parinc.com/spectra. That's SPECTRA.
Hey everyone, welcome back. I've got a couple of fabulous guests for you today. Dr. Emily Trittschuh and Dr. Jae Purnell are here to talk with me about gender-affirming neuropsychological assessment. So we have talked about gender-affirming care on the podcast, I think in one other episode, but primarily through the lens of providing gender-affirming letters or support letters for gender-affirming medical care. Today, we're looking through a little bit more of a neuropsych lens. So we are talking about things like what the literature actually says about brain-based sex differences. We talk about the role of test norms in gender-affirming assessment. We talk quite a bit about language considerations in gender-affirming assessment, and we touch on gender-affirming interviewing and report writing skills, among many other things. So let me tell you a little bit more about my guests, and then we will jump to this conversation. So Dr. Emily Trittschuh is a clinical neuropsychologist and the Associate Director of Education and Evaluation with the VA Puget Sound Healthcare Systems Geriatric Research Education Clinical Center. She's a professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington School of Medicine. She specialized in neurodegenerative disease and geriatrics throughout her career, and her clinical work and research has been focused on the full continuum of cognitive aging, from dementia to healthy brain aging into the 90s and beyond. At the VA since 2008, she developed additional and complementary interests in the care of older veterans who are transgender and gender diverse, and for those with PTSD and cognitive concerns. Her pronouns are she and her. Dr. Jae Purnell is an early career neuropsychologist, clinical neuropsychologist at the Center for Cognition and Communication in Manhattan, New York. He is queer and transmasculine. While his background has been more generally in neuropsychological assessment of adults and older adults, his passion projects center affirmative care of marginalized demographics, specifically for his community and adjacent LGBTQ plus communities. His pronouns are he and they. So this is a fabulous conversation. Like I said, we dive into quite a few areas of gender-affirming assessment, and really enjoyed being able to spend some time with both of my guests. I think there's a lot to take away from this conversation and plenty that you can apply in your practice tomorrow if you would like. So without further ado, here's my conversation on gender-affirming neuropsychological assessment with Dr. Emily Trittschuh and Dr. Jae Purnell. Jae, Emily, welcome to the podcast.
Hi, Jeremy. Thanks for having us.
Yeah, I'm glad to have you. I would love to just do a little orientation to your voices before we dive into it. This is kind of standard, with a couple different guests. So if you could just say who you are, a little bit about what you do. We've already done the bio, so you don't have to, tell the whole story, but just a little something to give people, a sample of your voice so they know who's talking throughout the interview. Jae, do you want to go first?
Yeah, surely. My name is Jae Purnell. My pronouns are he and they.
And hi, my name is Emily Trittschuh, and my pronouns are she and her.
Right. All right. I'm excited to have this conversation with y'all. We haven't talked a whole lot about gender affirming assessment on the podcast, and there's always more to say, I think, and it seems to be an ever evolving area in our field. So thanks for being here. I'll start where I always start with folks, which is, of all the things you could spend your time and energy doing in this field or in this world, why spend your time and energy on this particular area? Emily, do you want to go first?
Sure. So let's see. I finished up. So I'm a clinical neuropsychologist by clinical training, and finished up fellowship in 2008 and took a job at the VA Puget Sound healthcare system. And in that job, it was more of it is a memory disorders clinic, early diagnosis of mild cognitive impairment and things like Alzheimer's disease. And I was not actually prepared for working with folks who were not cisgender, and had a veteran come, and it kicked off for me an appreciation that professionally I was not done growing. I needed to push my boundaries. I needed to educate myself. There are some studies that show that the numbers of veterans who are transgender is about 2 to 3 times higher than if you just sort of look across the general population. It's sort of a whole nother topic to talk about why that might be the case. But regardless, that's a population that I have seen, and I wanted to do better, because when I went to the literature, there was really nothing there. Back then, this is like in 2009, 2010-ish, there wasn't even much in the general clinical psychology literature. So some colleagues at VA Puget Sound and we decided that we would write a paper kind of calling out the issues and the lack of information. And so then that kind of, my professional interests moved on from there. And I've had the luck and opportunities to work with many other awesome folks over the years, and try to push things forward a bit more and raise awareness, and be an advocate. I've also now in more recent years have personal connections with more at the teen adolescent end of things. And so while that is definitely not the area of Jay's or my expertise, because we're adult neuropsychologists, that is of course an important topic as well. I think as someone who finished their training when I did, there's a recent study that was published in 2022, led by Anthony Carrero, and I'm one of the authors on that, where we did a survey of neuropsychologists. And the demographics of the survey are that almost 98% are cisgender, and over 70% are heterosexual. So these are people out there practicing. However, when you ask people about their training, just broadly in LGBTQ plus health and neuropsychological assessment topics, people really only had gotten any training after licensure, and that was through their own efforts. And actually about somewhere between 20 and 30% reported never having had any training at all in this area. So I think that's a big deal. And it's also really why Jay and I appreciate you doing this podcast, because the prevalence, I hate that I just used the word prevalence, population estimates for trans folk and gender diverse folk suggest that this can be anywhere from 0.5% of the population up to 6%, especially if we consider a broader category. It can get broader if we include folks with variable sex characteristics as well. Sometimes that's referred to as intersex. And so this is a group of the population that, while I'm babbling now. I've had fellow neuropsychologists sort of in my age range comment like, well, I'm never going to see anyone who is gender diverse or trans, and they don't, I frankly think they may have already done so and they don't even know it, or they've somehow unwittingly sent them away with some sort of messages in their website, in their materials, that made someone perhaps not even feel welcome to approach them as a provider. And I think those are opportunities lost. And I would like to see that. I'd like to see that changed.
Absolutely. Yes. Well, you raised so many points that we're going to dig into, I think, over the course of our conversation. But I'd love to hear, Jay, just for you, what's meaningful about this? Why spend time on this for you?
Of course. So I think early on I recognized myself as one of, as Emily mentioned, one of few transgender people who are working in this field. And though my professional interests have not gravitated towards working within my community, my passion projects have. So this is in service to my own community. So I think that I did my first poster on this topic a few years back. And in doing so, my impression of the literature was that it wasn't getting good clinical information, but that much of it was actually actively harmful. So I am interested in having a voice in the body of work that exists. Um, I think it's important for marginalized people in professional and academic spaces to bring their lens to research and clinical practice. And then a couple of years ago, Emily and I connected, and I'd like to give Emily credit for this. She was actively looking for transgender people within the field who she could collaborate with because it's part of her ethos to center marginalized people as well in this work. And since then, we've been collaborating on different talks and educational pieces. And I found that the work that we do is very helpful to a lot of providers. And I love continuing to do it.
Yeah. Yeah. I feel so fortunate to have y'all here. I mean, I told you before we recorded, when we first connected, I found your presentation on the AACN agenda for this year. And I thought, oh my gosh, I got to reach out to these folks because the amount that we've talked about gender affirming assessment on the podcast is one, very limited, but two, not necessarily looking through this like more neuropsych lens. And that is super attractive. I think, even the fact that we're already talking about some of the research is pretty compelling. And I'm looking forward to getting more of that perspective here as we go along. I think y'all bring a pretty unique perspective that's both affirming, but also grounded in research. And there's going to be a lot to dig into there. So I'm glad to have y'all. Thanks. Thanks for being here. So with this whole thing, I know we had talked about maybe just kicking off with a discussion of language and what that might look like for our conversation and, of course, for the broader practice of neuropsychology. So where can we start with language?
Sure. So we both led with giving our pronouns, and I think in working with trans patients, that's one thing to acquire when interacting with somebody, so you know how to talk about someone. And then also, I think that the other point is just how a person identifies their gender, what gender descriptor they use. And we can talk a little bit about which kind of existing descriptors there are. I do want to give the caveat, as we've done previously, that language within this community has evolved tremendously and continues to. So the language that we might use in this podcast might outdate itself in the time to come. But I think pronouns and gender descriptors are kind of the starting point of things.
It also is, just as a sidebar, it's one of the things that makes doing a literature search in this area challenging, as well as the language has changed. And so while we are definitely would never promote the use of clearly outdated language, if anyone does want to do their own deeper dive into the literature, you may have to use some of the older, potentially less positive, less affirming terms. Or actually inaccurate sometimes. So that's a challenge. But Jay, do we want to go over any sort of, I guess I already used the term cisgender without explaining what that is.
Sure.
I don't think it's uncommon that folks who are cisgender don't know that they are cisgender, because that is a gender majority. And that is when one's gender identification matches the biological sex, or at the very least, the genitalia that was presented to the doctor that pulled you out at birth or on ultrasound and identified it. So it's a woman who's assigned female at birth, or a man who is assigned male at birth, and that actually matches with their gender identity.
Great. Yeah. Are there any other, well, I know there are others, but yeah, maybe just a little kind of like broad stroke, common terms, language that we're going to run into in gender affirming care. We can cover as much of that as you
Sure.
would like.
I will try to be brief because I know we have limited time, but there's so much I could say on this topic. So I will start from kind of more a simpler language to more complex language. And I do want to give the caveat that I think that even this is important for psychologists to be doing to honor the patient in front of them. But I also think that there's a reciprocal learning when we start to use different language to think about or describe people. It affects our perceptions of those people. And so being precise about the language we use is necessary and also helps the provider conceptualize the person accurately. So kind of to start, general pronouns, he, she. I think one that's come into popularity also has been they, them as a singular pronoun, which we use routinely, but typically not to discuss a specific person after we've met them. But I think those are some of the more common pronouns used. There are other neo-pronouns that are less frequently used. And then starting, a transgender man is a man who was assigned female at birth. A transgender woman is a woman who is assigned male at birth. A couple of words that I want to use that I think are used more frequently in the trans community are transmasculine and transfeminine. These words are more expansive because they describe identity along the lines of masculinity or femininity, and they're a little less binary than trans man or trans woman. So, for example, transmasc or transmasculine, which I use for myself, can encompass transgender men, but also non-binary people. And then that's, I think, another important one. One of the shifts that we've seen in population estimates has been due to the inclusion of different gender identities, including non-binary gender identities. So I think that
and gender fluid as well, right, Jay? Right. In terms of thinking about, there's folks who are not just static in their gender identity as well.
Totally. And when we give these presentations, we usually use the term TGD, transgender and gender diverse, to include people who are transgender, but also just generally to be expansive and encapsulate non-binary people who might not identify as transgender, or anybody else who has gender questioning people, but anybody who is not cisgender.
Sure. So
and it's better to say gender diverse, transgender and gender diverse than not cisgender, because then you are making it an exclusionary different than statement rather than a statement of who people are. Does that make sense? Like I think I've seen that before. Oh, my patient was not cisgender. Okay. Is that helpful? I don't think so. I don't think they would say it's helpful. Yeah.
Right.
Sorry to cut you off there.
No, that's an important distinction. Yeah. I mean, I think that dovetails well with how we maybe write in our reports too. Like we want to use more affirming language across the board rather than like someone was not something. That's just sort of confusing and overly complicated. But one of my, I think, I see my job in a lot of my podcasts is to ask questions that people might be thinking out in the audience. And sometimes that means asking what might be dumb questions, right? But I'm just going to go for it and hope that someone out there is also wondering. But just quickly, talk about the difference between trans or gender diverse and non-binary. I'm sure that there are folks out there who are like, well, what does non-binary even really mean? Like, are we, what do we do with that?
That's a fantastic question. And I think it's so individualistic, right? I think that if you're using, interestingly, like binary categories of trans and cis, right? Most non-binary people would fall into the category of trans because they do not identify with their sex assigned at birth, or exclusively so. But this is really individualistic. There are non-binary people who the term transgender just doesn't resonate for them. So I think that's a simplistic explanation, but it is also probably the one that exists.
Yeah.
Yeah. And I think for people whose identities are strongly masc or strongly feminine, whether they're trans or cisgender. If you're strongly masculine or strongly feminine, it may not be so easy to imagine sort of not feeling either of those strongly, right? And that could be the non-binary is that I don't feel gendered kind of, or sorry, that sense of that genderness is not the way it is for others.
Right.
I like to think about we think about the spectrum of kind of masculinity and femininity. And Emily's kind of hinting at this other spectrum that is like highly gendered versus like less gendered. And so for some people, there is a sense of high gender resonance in one or more ways. And for some people, there's kind of the absence or the dissociation of gender.
Yeah. Yeah. That's a good way to put it. I mean, that's easy to kind of wrap our minds around, I think. And so the other, I just want to like name the other kind of variable out here that we're not talking explicitly about, but, maybe comes in to this whole discussion is the sexual orientation question, which is also, there's an intersection there of, who you're interested in as well as like how you identify. Right. And I don't know that comes into the neuropsych process as much, but I think I'm just naming another thing that comes into the discussion and maybe throws people off when we really simple, clear, familiar labels and whatnot. Right.
Well, and I really am glad you're bringing this up because this is important to know. And everyone should know it, whether you're a neuropsychologist or not. And that is that historically, there's been a real conflation of sexual orientation and gender, and they can become they're different. They're different dimensions of who someone is or can be. Right. So one can be cisgender or transgender, and you could be gay or not gay or straight, right? These are the sexual orientation is based more on, I'm just gonna be blunt. Who do you want to have sex with? Do you want to have sex with everybody? Do you have a particular affinity toward a gender or not, a different gender, or, binary? Sorry, not binary, but bisexual. So there's a lot of options. They run separately. And so to make an assumption that someone who is trans is homosexual would be just as kind of what I think we currently in our society would think is as ridiculous as assuming that because someone is cisgender, they must be straight. They must be heterosexual. I think we pretty much are knowledgeable about that at this point. So does that answer it enough? It's, Jae introduced me to this graphic. It's called the gender unicorn. And I bet someone can Google that and look up the gender unicorn. There's lots of similar type graphics out there, but it's a really nice visual for a reminder that there's these different dimensions of gender identity, gender expression, with that whole sex assigned at birth thing, as well as, sometimes people have sexual attraction that is different than their emotional attraction as well. So it could be something that if someone wanted to do a little bit more reading on, they could pull up.
Yeah, absolutely. I'll put a link to that in the show notes. I've definitely seen that graphic in the past. So it's a good one. Yeah. Thanks for talking through some of these things. I know super, super basic, but it's all part of the picture, right? So anything else language-wise, at least here at the beginning of our discussion, before we dive into some other aspects?
I just think that, you hinted at this, and I don't want to jump ahead, but when you're in the room working with a trans patient, this is one of the quickest ways to build or break rapport is with language use. And also, as it pertains to report writing, the language that you use to refer to the individual or their gender should be reflective of the language that they use for themselves. So thinking about language within the context of the end result and how a person will be talked about throughout the process. But I also think it's imperative for building rapport, even if it's, for a quick assessment.
Sure. Can I ask kind of a nuanced question with that, that y'all may or may not be able to speak to, but, I work with kids primarily. I know you're both adult oriented folks, but the question that comes up a lot for us is, do we use the minors prefer, pronouns, or do we not? If there's a conflict there between what the parents would prefer and what the kid wants. And I don't know, we talk about this fairly frequently, actually, and it's a tricky one. So I'm curious what your perspective might be on that.
My perspective is that I would use the kids prefer, that preferred, use their words they use to describe themselves. You can comment that parents use different language. But I see what you're saying, they're not the one paying for the eval, but they're the one that you're trying to provide services for. So maybe that's the stronger director. And maybe for some folks that's difficult because they get pushback from the parents, but then that's probably an issue to explore right there. Because I don't work in kids. I do, though, work with a lot of adults who have adult children or other family members that are involved. And I think every clinical psychologist knows this. You're rarely treating just the individual in front of you, whether this is a neuropsych evaluation or psychotherapy. There's a lot of vectors involved in trying to help and assist someone with moving forward.
Absolutely.
Jay, would you add anything there? I know you don't disagree with me. I just don't know.
Jeremy, in this moment, I'm so glad to be working with adults and have never run into this. Because it's complicated. I mean, I do also think about the who consumes these reports, right? And if it's other providers in the future, it will teach them how to speak to and about the child who is the patient. And I think I see this in various different ways through different institutions. If you misgender a person in one report, that will be replicated down the line and create problems for their care later on. So I agree with Emily, but I also think that if there are additional providers who will be the consumers of these reports is especially important.
And can I take a second? I would like to call myself out on a mistake I just made. I used the expression preferred. And I caught it right away, but I actually really want to call that out because that is sometimes in reports. I see that. I should not have said that. It's not that kid's preferred pronoun. It's the pronoun they're using for themselves. That's their pronoun. Now, in kids, from what I know from the literature and from colleagues that are pediatric neuropsychologists in this area, there's more fluidity of gender in younger people. It tends to get more fixed with age. So maybe that was some of what was driving that bad usage. But that's one of the things I see in reports that's well-meaning, but is a microaggression to imply that somehow oh, well, I could use this pronoun, but I'm going to use this one instead because I like it better. That's the sort of thing that as a cisgender person, and especially being a little not so young anymore, I really have to retrain myself to not say things like that. So I'm calling myself out.
Yeah. Well, I appreciate that. I'm sure. Yeah. Y'all probably noticed I did the same thing, right? As I was asking the question, right. And it came out halfway. So yeah, I appreciate you acknowledging that. I will do the same thing. That's one of those things, just talking about language, that I have seen, once I became aware of that, using preferred or not using preferred, I started to see it everywhere, in our paperwork, in our EHR system, in, other literature. It's just one of those things that is important and contributes to the whole vibe, I suppose. But I appreciate you calling attention to that.
Right. So yeah.
Can I add one on?
Oh, please do, Jay.
There's the term. I mean, there is. I think there are places where this can be useful, but identify as.
That's
I think that when we're talking about a cisgender person, we would never say they identify as a man, right? We would just say is a whatever-year-old man. And I think that this is a way to kind of minimize a person's identity when we talk about them or write about them. So I think that the term identify as, and what I've said to providers is, if you wouldn't use the language in reference to a cisgender patient in describing them, then don't use it for a transgender patient.
It's a great way to put it. Yeah. Yeah. There's so much to, yeah. I feel like we could talk about just the language
That's
component
tough. Yeah.
for
Right.
an hour, I mean, there's just so many of these instances, but I appreciate y'all, highlighting a couple of the bigger ones that also may fly under the radar, because they kind of masquerade. I'm just going to keep going, even though I'm trying to stop myself. I feel like they masquerade as affirming, right? Because that, I don't know if that's how it started or what, but like, we're like honoring, quote unquote, the preferred pronoun, or like we're naming how someone identifies. But then, as we go along, it's more like, well,
Then
no,
you
it's actually
recognize that
just
you're
another way of,
undercutting.
right,
Yeah.
right.
Could you imagine
So.
saying, "Oh, that Emily, she identifies as white." I
Well,
mean,
yeah, there's an ethnic racial component to it. Yeah, I mean,
you can
this
just
there's
think
a
of all
parallel.
different scenarios where you just don't. Yeah. So I think what Jay
Sure,
said is the at the very end of the day, would you do this with a hetero cis white person? Yeah.
sure, sure. It's a good lens to look through. Well, let's dive into some of the practice, I suppose. Um, Practice wise, so we kind of get involved, at least assessment wise. I feel like what gets a lot of headlines, so to speak, is the like supporting someone through the transition process, right? Like maybe this is outdated, I don't know, but the writing the letter, like the letter to help someone like um um go through a medical process, right? I would love to hear from y'all though, like um, how we as neuropsychologists can truly and actually be involved in assessment with gender diverse folks.
Yeah, so I think it kind of broad strokes around the transition process. Transitioning is, I think that many cis people think it's a demarcation of some medical process or procedure, but there are different dimensions to transition. There's medical, and which may or may not include surgical transition. It may exclusively include hormone replacement therapies. There is the legal aspect of transition, which includes changing documents. And then there's a social aspects of transition, which may include changing presentation or use of different pronouns or community orientedness and building. And I think that in pop news and everywhere, the medical aspect is really highlighted, and it tends to be what people focus on and think about. But for the purpose of neuropsychologists and more broadly psychologists, that social and legal aspect is the place where we can really have a role in supporting a person. Once a person is granted the mental health license, they are emboldened to write these letters. And Jeremy, I wish this was an outdated process, and I could tell you that um, we aren't prescribed a role as gatekeepers to this process, but we still are, particularly for surgeries. And so I think that when we're conceptualizing a person for a neuropsychological evaluation, what Emily and I say is think about what would impact the evaluation. And the evaluation is the key component at the end of the day. So anything that you're asking about in terms of a transition or a process should be because it has clinical relevance to the assessment that's being performed. But as an aside, any of us have the capacity to write these letters. And I think that the social aspect also has the greatest impact on things like mood or psychosocial support, which are the real considerations when we're doing a neuropsychological assessment.
Sure, sure. This may be a super clumsy analogy, and feel free to call me out if that's the case. I wonder if this emerged. I don't know, the letter writing process, the gatekeeping process. Like I see some parallels between folks who are doing other things that should or could be under their own volition. Like I don't know. I think of like bariatric surgery or like surrogacy evals that we do, or things like that. I don't know if that's too much of a stretch, or if that's you know minimizing somehow on either side, but I feel like there's a precedent for this kind of thing in our field where we do gatekeep other things.
I think it's rooted in these ideas that there's somehow mental health issues that are causing someone to do something. Um, surrogacy. Is someone fit to carry a child? And then will they be psychologically able to give it up? Right. Bariatric surgery does someone have some mental illness that's the reason that they have a challenge with weight? And, has that been addressed sufficiently already? So I think your perception is really right on, that there is a component of that. And I don't know how soon we're going to get away from this outdated idea that someone's gender not matching with what an ultrasound or a physician said their genitalia looked like at birth is somehow a mental problem. But hopefully we're going to get there. Sorry, Jay, jump in. Yeah.
I think it's specific to working with a trans population. It deals with a mental health provider legitimizing a transgender person, right? I think that that has historically been what it is, and those are its roots. I think that we're moving towards, and I do like an informed consent model. I mean, I do think that the challenge inherently with having to see a mental health provider for the purpose of attaining one of these letters, one is it really positions often a cisgender provider to make the decision of, is this person trans enough, or adjusted enough, which they themselves might not actually have a ton of knowledge on. And then the other thing is we have to think that, trans and gender diverse people as a population often have economic barriers. And so accessing a mental health professional, especially when there are requirements for treatment before getting a letter, can be really hard. So in general, I think that the movement has been towards an informed consent model, which I think is progress, but I think it is still inherently flawed because there's difficulty gaining access to the people who would write these letters to begin with.
Especially those that have appropriate knowledge and background to understand the issues. Yeah.
Sure. I appreciate y'all commenting on that just for a bit. I would love to start to dive into some research stuff. We touched on that a bit ago, but I think that's super important. So maybe we just start with research on binary sex differences. That seems important in this whole discussion. What does that research look like? I mean, especially from a neuropsych perspective, but feel free to take this whichever direction you would like. Let's take a break to hear from a featured partner. Y'all know that I love therapy notes, but I am not the only one. They have a 4.9 out of 5-star rating on trustpilot.com and Google, which makes them the #1 rated electronic health record system available for mental health folks today. They make billing, scheduling, note-taking, and telehealth all incredibly easy. They also offer custom forms that you can send through the portal. For all the prescribers out there, Therapy Notes is proudly offering e-prescribe as well. And maybe the most important thing for me is that they have live telephone support 7 days a week, so you can actually talk to a real person in a timely manner. If you're trying to switch from another EHR, the transition is incredibly easy. They'll import your demographic data free of charge, so you can get going right away. So if you're curious, or you want to switch, or you need a new EHR, try Therapy Notes for 2 months, absolutely free. You can go to thetestingpsychologist.com/therapy notes and enter the code TESTING. Again, totally free, no strings attached. Check it out and see why everyone is switching to Therapy Notes.
The Spectra Indices of Psychopathology provides a hierarchical, dimensional look at adult psychopathology. Decades of research into psychiatric disorders have shown that most diagnoses can be integrated into a few broad dimensions. The Spectra measures 12 clinically important constructs of depression, anxiety, social anxiety, PTSD, alcohol problems, severe aggression, antisocial behavior, drug problems, psychosis, paranoid ideation, manic activation, and grandiose ideation. That's a lot. It organizes them into 3 higher order psychopathology spectra of internalizing, externalizing, and reality impairing. The spectra is available for paper and pencil assessment or administration and scoring via PAR iConnect. You can learn more at parinc.com/spectra. All right, let's get back to the podcast.
This is an area that is just so exciting for me. The concept of gender as a moderator of cognitive ability. So I think that there's been this history in neuroscience and neuropsychology around sex-based kind of performance, which is like there's a male brain and that there's a female brain, and there are these kind of distinct functional differences between these two types of people that will become evident during a neuropsychological assessment. And, I've done a lot of reading, and a couple of things have become evident. One is that, there's a publication bias that naturally skews us towards literature that highlight differences, right? So historically, when we look at the difference between men and women or male and female, I hate those terms. But when we look at those differences, I think that they're especially illuminated in the research. And I do think that type of publication bias tends to particularly negatively impact marginalized demographics, right? When we do comparisons based on gender or race or any of these other demographics which represent marginalization, there are people who are potentially harmed by this research. So when it's done, I think it needs to be done purposefully and carefully. This is to say, historically, we have seen this like kind of inflation of difference based on sex. And in more recent years, the kind of overarching theme is one, it is just so much more complex than that. So most of the research that exists is structural, not functional. So a lot of it is based on brain size or structural differences between brains, which is not a one-to-one relationship in what we see in terms of a neuropsychological assessment or cognitive ability. So as far as neuropsychologists are concerned, we really have limited available research on functional differences that are meaningful and recent. And then the other thing is, if you look at research that is exclusive to a particular region of the brain, you'll see these differences. But when you look at whole brains and you start to look at many, many people, because again, a lot of MRI research is small sample. So when you look at like meta-analyses or these kind of larger size studies, the differences between, men and women start to dissolve. And so I think at this point, the understanding is and should more broadly be that it's just so much more complex. The other thing is the human brain is not immune to psychosocial influence. And I think that there is this idea that I think is very interesting, which is the gender role mediation hypothesis, which basically describes it how over a lifetime, men and women have different abilities cultivated. And that will lead to the differences that we see in, functionally in cognitive performance. So a lot of this research has been done in academic settings where they look at math and reading or writing abilities in boys and girls that are school aged. And one of the interesting things that we've seen is that is culturally bound. The cultures that have less of an idea of differences have differences, don't see the same differences in performance on academic achievement tests. And the other interesting thing is that as we've kind of started to dissolve these ideas that are, I think, largely sexist in nature around ability level, over time, we've also seen a decrease in the difference in ability between math and reading, boys being better at math and girls being better at like verbal ability. So we know that overall that there is some aspect of cultural influence, right, and social influence, and what it is that a person can cultivate over a lifetime that produces what we see in terms of cognitive ability in adults.
Yeah.
Well said.
I'll also add that Jay's really referencing a forward-thinking set of body of research. If you go and look at older cognitive and brain anatomy research, it's deeply flawed, and many of those types of studies persist today. Just think about the typical recruitment flyer for a study. We're recruiting men to look at this, or we're recruiting older adults over age 50. Here's all of our exclusionary criteria. Oh yeah, we're going to do a physical exam as part of it. Do you know who's never gonna even walk in the door for that? I think those types of studies, especially ones that already tout themselves as looking at quote unquote sex gender differences, they're they're biased recruiting toward those extremes of masc and feminine. That anyone who's sort of not fitting that box is highly unlikely to be included. I think, and that leads me to commenting on feeling like, as much as I appreciate the rich normative data that have been developed by neuropsychologists and others over the decades, it's important to remember that recruitment flaw and data flaw exists in those studies as well, and in those published sources that we often feel really good using to help us identify what's impaired, what's not impaired. We try to use cutoffs, and we're trying to fit people into boxes that don't exist in that sample.
Sure.
I think that gender as a moderator is just oddly more individualistic, more nuanced, and less important than neuropsychologists often hold it to be.
Well, yeah, I think that's true. At least when I went through grad school, which was kind of a long time ago at this point, I guess, this is still a thing that we talked about a lot, was the male female brain. Yeah. I mean, that's a hard idea. It's a hard idea to shake. And I feel like it's kind of baked into everything we do. I mean, even, like our day in and day out work, there are male and female norms in the vast majority of measures we're doing, right? Like, so even if there's no difference between the two, it's still right there. Like, it's binary classified.
We pick. Yeah. When you open up the norms book, you what section are you going to after you've gotten your scaled score to go get your T-score, right? And some of these demographics, I work in aging. I would like to think that age doesn't matter, and I think in many ways it doesn't. But that does seem to be a more how do I put it? It's a safer thing to go with. And again, the goal is to not marginalize or be pejorative to someone. So you're trying to have them look their best. So making an age adjustment, has more basis. Maybe education, although we all know years of education is a proxy for so many other things. And it can be quality or not quality. So that also has a lot of flaws. And then, as we're talking about, gender is often awful to be using as a demographic factor for normative data, just like race is often really, really difficult.
If I may, just as this pertains to transgender people in particular, right now there's very minimal, I think, research on functional changes in trans people as it pertains to gender. When you look through the research, it's really hard to get good information about, okay, if there are these normative gender differences, how do trans people fit into all of this? Generally, what I've seen is that for people who have not had exposure to hormone replacement therapy, the research really varies. A lot of it tends to suggest that trans people kind of have a unique cognitive pattern that doesn't really correspond to, basically, we look different than cisgender people of either gender. There is also research that suggests that the more time that a person has been on hormone replacement therapy, the more they begin to approximate their gender in terms of cognitive performance. But again, a lot of this research that's been done has been small sample. It has not been long-term research, which has exclusively looked at binary trans people, trans men and trans women. So, as far as neuropsychologists are concerned, there isn't like a clear-cut answer in terms of how this all shakes out as it affects trans people.
Well, yeah, you're kind of anticipating some of my next questions, which are, what does the future look like essentially for trans folks in the neuropsych literature? I mean, will there ever be a day where we have like trans norms? Is that even something to be considerate? You know what I mean? Like, where does it go from here?
I'm sorry, I'm shaking my head, which of course in a podcast you can't see me doing that. in my journey, I and the folks that I wrote the first paper with, I mean, we really started off with this goal as soon as we were like getting into publishing it, that we were going to reach out. We had a community of folks across the country at different VAs, and we were going to collect trans norms. And then you start looking at what that would be like, and you realize that you at best would have an N of one for all the different variables. And it goes to what Jae was saying, and that this isn't about medical. At the end of the day, the medical piece of it, one, is so individual, and two, is not even existent for some people. There's just it's like it's just not the right goal. I don't think. What I think, and this is my opinion, is that what we need are non-binary norms that I could trust have actually been inclusive in their recruitment to really cover a full continuum of not just a continuum, but all dimensions of sex and gender. Folks who are intersex are not represented in any of this stuff either. And that's 1.7% of the population has variable sex characteristics, chromosomal, differences that are not just your basic XY, XX pairs. So that's where I would hope we could get is just to have just really, really rich norms that are inclusive.
Mm-hmm.
But you know what? Nobody wants to pay neuropsychologists to collect these data. That's a challenge. That's a whole different podcast. Who makes the money and who pays people to collect norms?
Sure.
Sorry. Go ahead, Jae. Were you going to comment there?
I'm just really excited about that question. I don't know that I've ever been asked it. So I think that there's two directions I think about. So one is I do agree with Emily in terms of where neuropsychology could go. If you tried to do trans norms in particular, it would still be hard to do a one-to-one when you're sitting with the patient in front of you, right? Because there's so much nuance to a person's gender or experience that I think that even if that was done, it would fall short in terms of clinical utility. But I using collapsed norms that encompass people, not just cisgender men and cisgender women, but encompass a range of genders, so that you could, have collapsed norms that are less, binary or homogenous. I think that could be the way to go for sure. And then I also think, a lot of the research that exists on trans people is really not, I think there's minimal clinical utility. I think a lot of people have looked at how are trans people different or how are trans people similar, right? And a lot of it seems to be rooted in wanting to validate or not a trans person in their experience. So I think that in terms of the general neuroscience or psychological literature, I think that we need to be thinking about how does it serve the population that's being studied, right? If you were going to look up information about how to do an assessment for, a trans person with a particular disorder, there would be nothing. But there's a lot comparing trans and cis people about it, is their gender in the brain somewhere? So I also think that the direction needs to go in clinical utility, and that serves the community.
That makes sense. So I just, maybe to clarify, and as always, just put me on the right path if I'm going down the wrong path. But it sounds like both of you are advocating in some sense for just norms, like combined norms, just norms,
good,
not male,
good
female,
norms.
trans,
Yeah.
just good norms. Yeah.
That included folks that don't fit just that cis binary.
Right.
Yeah.
Right.
The same way that we would say that a normative data set that's just a bunch of white males from Minnesota may not be the best to apply to someone from a different group, right?
Yes.
It's not that different.
Yes. I'm just laughing. It's always just white males from Minnesota, I feel like.
I'm from Michigan. We always call out, our northern, what we like to think is more northern than us, but they're not.
Sure. So that leads me to the question then of like, where do we actually stand now with trans folks and gender diverse folks with testing and norms? I mean, this question comes up a lot, for better or for worse, but it comes up a lot day to day and in the groups, and whatever on the listservs. Like, what norms do we use when we're giving these measures that demand, that we choose norms?
Can I just start by jumping in and saying that with the first person I worked with, used the tests. I knew I was working with a trans woman, and I used my standard test battery. I hadn't maybe read the chart carefully enough, but even then, I don't even think I knew to ask questions ahead of time. I just went in with a sense of, okay, well, this is new. And I used my standard battery. And in it was a particular verbal memory test, list learning test that is very popular. And at that time, that version of it had binary gendered norms. And I hit that moment like, oh crap, which norms do I use? And looking back, I'll tell you what, I would never, ever use that test again I frankly don't use it as a regular part of my evaluations anymore at all. And I definitely would not use it in that population. The same way, again, if you have someone coming in and there's no good norms for that population, don't use that test. So I think we can talk about what do you do when you end up in the position I ended up in. But what's the expression? The best offense is a good, I don't know. Like if I had just thought ahead of time, I would have used a different battery and I would have done better. There are tons of list learning tasks out there. I did not need to use that one.
Now that sends me down this whole path of, affirming assessment measures. That'd be a list I would like to see if it exists somewhere.
Jay has a list.
Exist somewhere?
Is it, Jay, do we have it just in our talks or do we have it in a paper at any point?
We don't have it in a paper yet.
I like that.
But I'm happy to send it over to you as well, because it's a nice shorthand. But I mean, and also to respond to this, I mean, there's 4 basic approaches to take to norming, right? You can choose norms according to a person's sex assigned at birth. You can choose norms according to a person's gender, if binary. You can use and choose tests that include collapse norms, or you can double score using male and female norms and compare to see if there are any clinical differences between those two. Personally, I would say, the research doesn't support using sex as a group for this population. I also think it's really an anti-affirmative stance, and those things, fortunately align. So I would never take the first one. In terms of the second, using a person's gender, I think it depends on, are there tests that I really need to give and only have binary norms? Are there, what's the clinical utility in choosing a test where I'm going to have to choose gender? And then if we're thinking about gender as far as norms are concerned, as a compound construct, right? There's socialization, there's, people have gone into the hormonal aspect of things, or the chromosomal aspect, right? We have all these different aspects of what winds up, for cisgender people align very neatly, for transgender people don't. And when we're thinking about the compound construct of gender, all of these different individual components, would I choose gendered norms for a trans person? Maybe, if I really needed the test, and if they had a binary identity and it's something that had been long established. My default would always be to use choose tests with collapse norms. I don't see any real value in double scoring and doing both. Other than I think that most of the time, a provider would find that even if there's minor, numerical differences between scores, there's not really any clinical difference. It doesn't change the range in which somebody is performing.
Yeah, I would agree with that. Right. Yeah, in the majority of cases.
Sure. For that person that I worked with, her scores were sort of hitting that mild cognitive impairment mark for verbal memory tests. And I didn't put it in the report, but I'll just admit back in I can't remember again exactly what year, but it's more than a decade ago. I did look up the not appropriate gender norms, just out of curiosity. And then I had a conversation with her at feedback about how I was leaning toward a mild cognitive impairment diagnosis because of weaknesses in verbal learning and memory. And frankly, it matched with her perception of what had been going on for her. And so we kind of had a discussion around that. And then I wrote the report. So there was transparency. That's another thing. If you're gonna do something like double score or use the wrong norms, sex assigned at birth, you better darn well, if you want to be ethical, be having a really clear conversation and explanation for why you would do that. I don't know.
That's a great point.
Again, we're talking about adults. Kids are tricky. I'm glad I can't imagine being a pediatric neuropsychologist. It would be so much harder.
It's so funny. I think the exact opposite.
Right?
We can agree to disagree.
I've had many people say that because I deal with dementia and I'm giving really those diagnoses are not easy.
Sure. Jay, were you going to?
As an aside, I do want to make note that whatever norms a person chooses to use, I think, especially working with a trans patient, the provider should note that so that if a person is retested, those can be, and hopefully they choose collapsed norms based on this podcast, or are thoughtful in their approach. But I think it's important to document what norms you're choosing to use so that the test can be done again, because I don't think another provider would naturally do what you've done on a test for a trans patient.
That's such a good point. Yeah. So let's see. I mean, we're certainly talking about a lot of the practicalities of testing. I'm curious what else, what we might want to be thinking of in terms of the other aspects of the eval, maybe the interview, maybe the report writing. Could we dive into either of those areas?
So Emily, I'm going to call out some of our conversation yesterday.
Oh, sure. Yeah.
I actually just had a conversation yesterday about how marginalized people, when we're working with the majority population, we are often unconsciously looking for cues that signal to us whether we can be safe or comfortable, right? And this comes up, I think, also very frequently when people reach healthcare professionals. There's, a history of mistreatment for many populations. So I think that the first thing is, when working with a trans patient is to cue them to let them know that you are a person who's hopefully knowledgeable and coming from an affirmative perspective. And I don't think that, visible signals like a pride flag in the office is great, but Emily has really beautifully said that can be undone in a single sentence during a clinical interview. So putting, these kinds of cues is fine. I think that some of the best things for providers to do is, one, have forms and documents that are inclusive, so that a person could, fill in their gender, not just circle MRF. I think during the clinical interview for, I'm speaking largely to, cisgender clinicians, asking questions that are important about language, about a person's experience, not asking things that could be considered medical voyeurism. The question that should be on the forefront of any neuropsychologist's mind during the interview is what I'm about to ask relevant to the assessment that I'm doing? And the trap that cis providers can fall into is the kind of medical voyeurism or curiosity of a trans person, right? So I think that keeping that in the forefront of our minds, or your minds, is really important. And then I also think letting a person know your limitations, right? Transparency. If you have to ask personal questions, giving a caveat before and going, I know this might be personal to you. Here's why I'm asking it. Or I haven't, here are my limitations. I'm not sure how to refer to you in this way. Can you tell me how to refer to you? Write this report. And I think that for most trans people, seeing that intentionality behind interacting with us is going to build rapport inherently. Even if you don't know everything, right? And I think that most psychologists who are not in the community will never know everything. Faux pas are going to happen. But being kind of clear about the intention that you're coming in with, being able to admit mistakes or course correct when necessary. Those are all really the things that build the initial rapport and signal to the person, the trans person in front of you, this is a safe person to work with. I can actually talk to them about what's going on. I can work with this person. I'll do an eval with this person.
Sure, sure. You use that term medical voyeurism. I don't know that I've heard it before, but it totally resonates. And I'm curious, off the top of your heads, as someone, I'm just, thinking about myself, like I probably err on the side of gathering too much information than less, I think. And so I'm just kind of thinking through, like, how could I trust myself as a provider not to inadvertently sort of ask questions that aren't relevant or might be perceived as medical voyeurism, if that makes sense. So I wonder if y'all have examples from cases in the past, or even ones, if you can think of them just off the top of your head, of things that we probably don't need to be asking about in most cases if we're working with trans folks.
So I think where this is going to come up the most is around medical and surgical history during the interview, right? So I think that the approach again is to in that area, maybe clarify why these questions are being asked, and then ask questions that we would ask any patient, right? Do they have about their medical conditions? Have they had any surgeries? What were the nature of the surgeries? If that's relevant, but also not get into the details. I think the biggest thing is to really veer away from curiosity about a trans person's body. I think that that's where the voyeurism really becomes illuminated. And we see this in pop culture also, right? Or curiosity around surgeries or medical procedures with kind of this idea of what has a person done, or how have they changed their body, as a curiosity. And so I really just think when asking, especially around like the medical and surgical history, it should be limited to what's going to affect the assessment, right? And if there are details about a person's transition that aren't going to have any impact on their cognition or what's going on right now, then it really doesn't need to be asked.
Yeah. You wouldn't ask a cisgender woman if she's had a breast augmentation in a neuropsych, or, in a neuropsych evaluation. And you wouldn't really ask that same cisgender woman if she had a double mastectomy in her 20s and you're seeing her in her 50s for a cog eval. Were you going to ask about that? Like, it's like important for the eval. Now, maybe a history of cancer is important. Is she still on tamoxifen or something? But I guess, so the point is it's tricky. It's very easy to make a mistake. And as Jay said, being transparent of like, okay, so I may make a stumble here. I'm in for, I agree with you, Jeremy. I really work hard. I'd always rather gather more data. Sometimes my patients come in from really far away, and a lot of them don't do great on the telephone. So calling later to gather something I missed is not my goal. On the other hand, be a little knowledgeable. Do some reading and have a sense of like, okay, well, what are the types of hormone therapies? Is it possible that in the first couple months of initiation of a certain type of hormone therapy, could that have someone not performing at their cognitive best? Right.
Right.
So just it, and so that there could be some legitimate questions for timing of certain things. But as Jay's been educating me, hormone replacement therapy, like there's microdosing, there's all sorts of variables there that it isn't even just like I went on hormones and now I'm on this and I do the exact same thing every day for the whole rest of my life, right? So, yeah.
What we know of HRT and cognition, or what I know of HRT and cognition, is there's no direct detrimental impact. There might be a slight enhancing effect for some trans people on hormones, which is interesting. But I think that the relevance of starting HRT, that time might demarcate a particularly, challenging or just fluctuating time in a person's life. So I think about kind of psychosocial circumstances as like the mediator between hormones or hormone initiation and is this a good time to test or not?
Okay. Can you say a little more about that? Can you, give me any more thoughts, any more details there?
On HRT and cognition?
Well, more that second part of what you said, as far as the timing and psychosocial impacts, and how we might think about that as people come to us for evals.
We write reports all the time about how psychosocial stressors could be having an impact. Those can go in a positive direction, they can go in a negative direction, and frankly, change, even if it's like for one's like desired change, brand new job, moved somewhere you've always wanted to move, there's just still effects. So I don't know that I don't think that fully encompasses what you're getting at, but it's important to think of it in that way. um Sleep sometime, I mean, sleep's far more indicative if someone's been getting regular sleep versus dramatically affected sleep on how they're testing, or if they've had a period of depression and you're testing them during that instead of when they're euthymic. That I would say is much more likely. I work with a lot of veterans who have chronic post-traumatic stress disorder, and I would not interpret data from an evaluation without considering what their current, ratings are of not just like some other clinician, but what they tell me that day, their last week has been like in terms of their symptomatology. And that's got to be incorporated.
Yeah, I think what Emily said, right? It may be a big life event for a person. Also, it might not be. Somebody might be like, I've been out for a long time. I just started microdosing testosterone and it's not that big of a deal. Though there can be mood changes, right, in response to starting hormones. So that's also one of the kind of psychological aspects of that person's like that period of a person's life. But I think of it the same way. Like it may be a big change time in a person's life.
Yes.
Yeah. So maybe getting the information, but then asking the follow-up questions of like, well, what has that been like for you? How are you feeling? Have you, are you noticing it, not in a voyeuristic way, but like, are there effects in terms of your mood or energy or sleep or?
Absolutely. Yeah. Yeah. All those questions we would likely ask, for other concerns, right?
Exactly. Exactly.
Yes. So I would actually double click on that point about hormone replacement therapy and cognition. That was interesting. And you said that to your knowledge, there is nothing around detrimental effects necessarily, but there may be a slight enhancement of cognitive.
Yeah, there's a study I saw recently where there was like an some enhanced visuospatial ability as a person's been on HRT for a while, both masculizing and feminizing hormones, which I don't understand anyway. I'm not an expert on it, but what we know is that in terms of direct effects, there's not a person's memory or attention is not going to drop on an account of starting HRT. None of those are concerns. There may be other mediating effects long term, like changes in health that might impact a person's cognition. But there are no direct or immediate effects of HRT. Well, negative effects of HRT on cognition. So
Great.
If a person's just started a couple of months ago, a neuropsychologist does not need to be concerned that if a low score is evident, that it's because of this. I think that is to say that.
I gotcha. Yeah.
Unless they tell you they haven't been sleeping and because they're having night sweats, and you know what I mean? Like, again, it's you have to fill in the whole picture.
Yes. Yeah. I'm getting a theme here. Yeah. Thanks, Emily. It's the other facts. Psychosocial factors are important. We should ask about those. Well, I know there's no way to capture all of this in 1 hour-long discussion, so I'm not going to try, but I feel like we've covered a lot of ground. I appreciate everything that y'all are sharing. Is there, a couple questions just to start to wrap up. I mean, one, the general question of just, is there anything huge that we missed that you want to make sure to get out there before we wrap up? And then two, resources for folks who want to get better at this, want to learn more, want to do better work.
Jae, we haven't brought up intersectionality at all.
So yeah, intersectionality, when we're talking about being trans or gender diverse or gender overall, it doesn't exist isolated from other aspects of marginalization, right? Which can be confounding and exponential. I think that the big takeaway is in interacting with a trans person, there's a level of like base knowledge that a person should self-educate. And then when you're with a person, there's a lot of individualism, right? Even all of the training that you can get on trans people might not be applicable when you're sitting down with a patient in the room. So I think that the big takeaway I would love for providers to have is to be thinking about gender and working with trans people in a way that is thoughtful, self-aware, and nuanced. I mean, the big recommendations that I would have as like kind of a 101. So WPATH is one of the organizations that sets the standards of care for working with trans people. And they're more medically oriented, but I think that they have a lot of good resources. It's also good to get acquainted with them as an organization. And then APA did put out a kind of a, what do you call it? A paper on what like general guidelines for working with trans people that I read through and was, I think, pretty good. I think they did a pretty good job. So I think that's also a great general starting point. And also, I mean, I think Emily has, done a lot of really great work with a lot of great people. So I would also, sorry, I can do this to you, Emily. I I would also read some of the work that Emily has done in specific to the field of neuropsychology.
Fantastic.
I would stick with the most recent article that was from 2022 that is about affirmative care and was pretty equally in authorship for cis and trans voices. That original fledgling article feels very cringy now. I wanted to mention, I had Testa in my mind, and that is who it is. From 2015 is a key article that is on the development of the gender minority stress and resilience measure and a model for taking the minority stress model a step further and appreciating how that could be slightly more nuanced when the stress and trauma could be due to being in the gender minority / being marginalized. So it's Testa and colleagues.
Great. Yeah, and we'll put links to the show notes or links in the show notes for all those resources that y'all are mentioning.
And if somebody wants to do a deep dive, there's a book called Trans Bodies, Trans Selves that really gets into it's predominantly worked on by trans people. And there's also quotes directly from trans people on their experiences in healthcare and other things. But if a person really wanted to do kind of a deeper dive on understanding working with trans people, I think that's a fantastic book.
Great.
I have another one too. Sorry, I can't believe we didn't bring up the Queer Neuropsychological Society.
Oh, yeah.
QNS is a somewhat young, but now really getting quite well established identity organization, as there are others: Hispanic Neuropsychological Society, ANA, et cetera. And they not only have wonderful resources, you can get involved with QNS, but they also have a consultation option too, to set up and meet with folks and get peer support, because not everybody may be in an environment where they have colleagues with whom to work and who have more expertise. So I really highly recommend, it's a plug for QNS, Queer Neuropsychological Society.
That's great. These are fantastic resources.
I think we're actually done now.
You don't have to be done. We can keep going.
Oh
People
no,
have
you should.
resources.
You'll have to cut us off if Jay and I really get going. It's yeah.
Yeah.
Come join us at AACN for our 3-hour workshop.
Yeah, that's right. So just in the event, I mean, I'm thinking about time and timing, and this is a dumb question again, will that be available after the fact as a recording for folks who can't be there in person or listen to this after the presentation?
It is. We actually did the virtual recording over a month ago. It will not be nearly as fun and dynamic as us in person. We bemoaned the loss of the interactive component. We have that with you here. This is why podcasts are kind of awesome. Yeah, so that the contents will be available, and there's other recordings available as well. We have spoken for QNS. There was a NAN workshop that I believe was recorded. I might be wrong about that, but there are some things out there as well.
Great. Well, yeah, people know where to find you, and hopefully they will dive into a lot of these resources and info that y'all are putting out there as well. Yeah. I mean, it's clear that you know a lot and have lived a lot, about this area, and just super grateful that you're willing to come on and chat with me for a little while. So thank you. Thanks for being here.
Thank you.
All right, y'all. Thank you so much for tuning into this episode. Always grateful to have you here. I hope that you take away some information that you can implement in your practice and in your life. Any resources that we mentioned during the episode will be listed in the show notes, so make sure to check those out. If you like what you hear on the podcast, I would be so grateful if you left a review on iTunes or Spotify or wherever you listen to your podcasts. And if you're a practice owner or aspiring practice owner, I'd invite you to check out the Testing Psychologist mastermind groups. I have mastermind groups at every stage of practice development: beginner, intermediate, and advanced. We have homework, we have accountability, we have support, we have resources. These groups are amazing. We do a lot of work and a lot of connecting. If that sounds interesting to you, you can check out the details at thetestingpsychologist.com/consulting. You can sign up for a pre-group phone call, and we will chat and figure out if a group could be a good fit for you. Thanks so much. The information contained in this podcast and on the Testing Psychologist website are intended for informational and educational purposes only. Nothing in this podcast or on the website is intended to be a substitute for professional psychological, psychiatric, or medical advice, diagnosis, or treatment. Please note that no doctor-patient relationship is formed here, and similarly, no supervisory or consultative relationship is formed between the host or guests of this podcast and listeners of this podcast. If you need the qualified advice of any mental health practitioner or medical provider, please seek one in your area. Similarly, if you need supervision on clinical matters, please find a supervisor with an expertise that fits your needs.